Thank you so much for that introduction, and so good to see so many familiar faces here. So, let's see. Great. Okay, great. So today I'm going to be talking about factors associated with completing EBPs. And I want to just start by acknowledging co-authors that are listed here. And if you want to see the full publication, you can find that at Psychiatry Research. I'm also happy if you email me to send it to you as well. So luckily we have a very well-informed group here in the audience. Most of you know that the VA has implemented a national rollout of 2 evidence-based psychotherapies, including prolonged exposure and cognitive processing therapy. As a reminder, despite tremendous implementation efforts that started in 2005, relatively few veterans receive CPT or PE, and that among those who do initiate, local and regional investigations have found that veterans often do not complete treatment. So we had 2 research questions. We wanted to know what are the rates of initiation and completion of CPT and PE among Iraq and Afghanistan veterans who were diagnosed with PTSD, who received some VHA psychotherapy between 2001 and 2017, so we were looking over a large period. And that we also wanted to know what are the patient and treatment factors associated with CPT and PE initiation as well as completion. So we identified a national cohort of 265,566 Iraq and Afghanistan war veterans. They had a post-deployment PTSD diagnosis from 2001 to 2015. That was either 2 outpatient or 1 inpatient diagnoses. And they had an initial post-deployment mental health visit, and they had to have at least 1 coded psychotherapy visit with PTSD as a primary or secondary diagnosis by at least 2017. So we focused on more recent era veterans since they are more likely to have their post-deployment visits in the electronic medical records, and their service is closer to the date of the EBP rollouts. So there's a much larger paper on this that I would refer people to if they were interested, but we identified sessions of CPT and PE using natural language processing. For those of you who are interested, the article is cited below, and I'm also happy to email people. So we were able to use natural language processing and to look at note title, to look at note text, and the accuracy statistics are displayed here, so you can see quite high for PE, CPT individual, as well as CPT group, which we were able to kind of break down CPT individual and group to look at those separately. So in this particular analysis, we looked at 3 hierarchical outcomes during any 24-week period. For those of you who are clinicians, you know that CPT is often a 12-week treatment. We wanted to allow double the amount of time since we know that there are barriers for people coming in and getting the treatments on a weekly basis sometimes, so we wanted to give people double the amount of time to complete these treatments. And we looked at treatment completion, which we defined at completing 8 or more sessions, as you've heard here today. That's a good marker to use. Early termination was receipt of 1 to 7 treatments or no CPT or PE treatments. So we looked at a number of dependent variables, and those are listed here, sort of the traditional ones, which include socio-demographic characteristics, military characteristics. We looked at mental health comorbidities, history of suicide, ideation, or attempt. We also wanted to look at trauma exposure variables, including military sexual trauma and combat, as well as looking at medication. The year first mental health visit, as we know, as the rollout went along, more and more people were engaged, and so we wanted to look at what year people engaged. And then we also wanted to look at prior non-CPT or PE psychotherapy sessions, and finally CPT format, whether it was group, individual, or both. So we use separate ordered logistic regressions for the 3 category outcome variables. So again, looking at no CPT or PE, early termination, or completing. And then we also performed a separate binary logistic regression for the 2 category outcome variable. So we wanted to look specifically among those who initiated some treatment, what predicted early termination versus completion. So these are the results. Again, I want to remind people that these are among the veterans, the Iraq and Afghanistan veterans who initiated, were in mental health and had received some psychotherapy. So you can see here from 2004 to 2017, there were a number of people who received some EBP sessions, with only 7.4% of those veterans who actually completed, meaning 8 or more sessions for CPT, and 1.9% who received 8 or more sessions for PE. These are the results of the PE ordered logistic regression, and so just to orient people, you'll see that on the top are the variables. These are selected variables because there are many more, but I kind of selected the ones that I think would be of most interest to this group and were the highest odds ratios. So the top kind of variables are the increased likelihood of completing progressively larger number of PE sessions, again with that 3-part variable. And so age, not surprisingly, as we've heard about, so the older you are, the more likely you are to complete a larger number of sessions. Black veterans were actually more likely to complete as well. Those with MST were more likely to complete a larger number of PE sessions, and those with pain disorder and TBI, as well as suicidal ideation, were also likely to complete a larger number of PE sessions as well. Not surprisingly, those with schizophrenia, veterans with schizophrenia, and those who were from rural areas as compared to urban areas, there was a decreased likelihood of completing a higher number of PE sessions. So I want you to try to remember as best you can the slide of what for PE. So now when we move to CPT, you can kind of compare because those predictors are quite different. So with definitely some overlap. So as you can see, combat and age both predicted increased likelihood of completing progressively larger number of CPT sessions. And then additionally, if you received group treatment for CPT, you were also likely to complete a larger number of sessions, as well as if you were an officer. Interestingly, PTSD medication, if you were receiving those, you had a decreased likelihood of completing a larger number of CPT sessions. Okay, so these are the results of the binary logistic regressions. You can see here we were able to look at the number of psychotherapy sessions before PE and CPT. So what we can see here is that it's statistically significant for both PE and CPT, meaning those who received a number of psychotherapy sessions before PE or CPT were more likely to complete. You can see it's a small effect size, so it's just greater than 1. You can see that odds ratio is pretty small, but I think it's still noteworthy because a signal is there. For PE completion, age, combat, and Black veterans were also had increased likelihood of completing PE for that binary variable, and for CPT, age, combat, and CPT format again shows up as showing an increased likelihood of completing CPT. Now, I will say, you know, for those of you who are going to be at ISTSS in a few weeks, I'm going to be presenting part 2 of this talk, which is what factors are actually leading to improvement, which is looks different than this. So, so that's a little cliffhanger for those of you who are coming. So I think that that's an important factor here, that just because someone completed doesn't necessarily mean they improved. Okay, so how do we summarize these data? So over a 15-year period, 22% of veterans diagnosed with PTSD who received some psychotherapy initiated CPT and PE, and 9.1% of veterans completed 8 or more sessions. We found that there were several demographic, military, and clinical factors that were associated with completing at least 8 or more sessions. We found that MST was associated with completing more sessions of PE but not CPT. And I think it's interesting as more MST coordinators are facilitating access to care, I think that we're seeing an impact here on EBPs as well. And I think that, you know, we also know from data that there's high rates of healthcare utilization among MST survivors. So hopefully that healthcare utilization leads to more completed EBPs over time. So also interestingly, those engaging in other psychotherapy prior to CPT, PE was associated with completion. I'm just also wanting to remember what Shannon was saying earlier about the trust and building a relationship that came into some of her findings I think might be relevant here as well. And so I think we need to better understand this through the kind of work that Shannon is doing. What if there is actually a signal there, what is that about? So I think, again, the trust in providers, and there might be other things, and I think in a lot of the programs, skills building is a really important piece that sometimes people engage in stress management or anger management so that they can have the skills to get through CPT and PE. So thinking about that a little bit more. We also found that Black veterans were more likely to complete PE, and I think that that's also important to better understand. I think that a better understanding of race-based differences in completion is, I think, a great project for someone to take on. I think that we certainly are finding that race-based trauma has an effect on people, and I think we're looking at that in our medical center too. And so I think better understanding that in the future and how the impact of race on some of these treatments is important as well. So I think this is the first time that initiation and completion of CPT has been nationally examined over the course of more than a decade following implementation. I think that we also, for future directions, we need better understanding of why those with MST, suicidal ideation attempts, TBI, and pain are more likely to complete PE. It's a question mark that I think we just need more information and more studies done. As well as shared decision-making and diverse patient preferences. I think we also need more research on whether brief prior psychotherapy can assist with EVPs, as I mentioned, and provider-level predictors are important to continue to examine as well, which we can't do very well in this data set. So I just want to thank everyone, and please feel free, I want to acknowledge our funders, and also please feel free to email me with any follow-up questions if we don't get to them here today. Thank you so much.